Welcome to the ADHD Women's Wellbeing podcast. I'm Kate Moore-Youssef, and I'm a wellbeing and lifestyle coach, EFT practitioner, mum to 4 kids, and passionate about helping more women to understand and accept their amazing ADHD brains. After speaking to many women just like me, and probably you, I know there is a need for more health and lifestyle support for women newly diagnosed with ADHD. In these conversations, you'll learn from insightful guests, hear new findings, and discover powerful perspectives and lifestyle tools to enable you to live your most fulfilled, calm, and purposeful life wherever you are on your ADHD journey. Here's today's episode. So hi everyone, welcome back to another episode of the ADHD Women's Wellbeing podcast. I'm Kate Moore-Youssef, your host here as always. And today I am talking about a subject that we've talked about quite a few times on the podcast. We're talking about hypermobility, we're talking about Ehlers-Danlos, we're talking about the brain-body connection, and we're blending it all together with amazing knowledge from osteopath Alexandra Orfanides. I hope I've just pronounced that correctly. Alexandra is a London-based hypermobility specialist osteopath. She hosts Help, I'm Hypermobile, and has a book out the same name. Alex believes incurable does not mean untreatable, and she's on a mission to help the hypermobile community feel seen, supported, and informed. I've been so looking forward to this conversation. Thank you so much for being here, Alexandra.
Thank you so much for having me. I can't believe how time has flown since we first connected, but I think it was back in autumn, and it's been so
Yes.
busy season.
Yeah, I mean, listen, I know that book writing and then getting it out there and all the things that you just want to keep adding, and then you keep this new research coming out and you kind of want to
That's the worst
condense it
part.
all. Yeah, and because you're working in an area that is every month and it's growing and we're understanding more. And a few years ago no one would know really this connection between neurodivergence and hypermobility, and understanding what that all means, and not just thinking it's just like you can bend your finger backwards, but just all these different layers and health challenges. And yeah, I mean, I think I've never met anyone who understands themselves through a new neurodivergent lens that doesn't have a physical condition or hasn't gone through chronic pain or fatigue or different ways that it can manifest. I'd love to hear a little bit about your story and obviously what led you into osteopathy, but also what led you down this route that's very specific, being a hypermobility expert. So go for it. Tell us what all the juicy bits that you think is important for us to know.
It is a long story, so I'll do the condensed version. I have like the full version in the book if anyone wants to look at that. But in terms of my personal journey, so I grew up, just had a normal life, as we were talking about earlier, in London, Ontario, Canada. So the joke is I've always lived in London. I've lived in London, UK for the last 12 years or so. I had a quiet childhood, which I thought was normal, but it wasn't normal. I had pain constantly. My earliest memory is my mom tickling my knees because she was trying to make them hurt less, but I was in agony. And as a parent, I think, I speak with a lot of parents, and it's hard when your child is in pain, but the medical doctors say it's fine. And she was just trying her best to support me at that point, and the tickling did make me laugh at least. So anyways, I was dealing with constant pain, which I was told was growing pains, but it was definitely not that in hindsight. I had a lot of gastrointestinal issues, which I obviously still have because I'm hypermobile, which we'll get to in a minute. But those from an early age, like diagnosing a 10-year-old with IBS or gastroesophageal reflux, that should trigger some investigations. I had multiple other issues, chronic muscle and joint pain, neck pain in childhood again, which when a child is saying, my neck's in agony when they're studying, again, people just would say, oh, it's because you're so anxious, you're so stressed. Being one of those very studious children, it was always blamed on my studies or on my physical activity. So I was a very, very, very active child. I was swimming at a pretty high level on like my local team, training often 4 hours a day, and just doing that high volume of physical activity. They'd say, oh, well, your neck's in pain or your shoulders hurt or whatever because of your swimming. And in hindsight, again, yes, overtraining absolutely did contribute to injuries and potentially exacerbate some underlying symptoms. But at the core of it, there was something really serious going on. I then had to cope with a few difficult things in my life. So as we mentioned, my mom died of cancer when I was 21. It was a misdiagnosis despite repeated complaints, and she was told it was anxiety for a year and a half, or it was menopause or whatever, and it was none of those. Yeah, it was triple negative breast cancer. So because it was caught late, it was untreatable. I then ended up dealing with that throughout my first degree, which was English literature. And a lot of people, they're like, oh, was it a waste to do an English literature degree? And that is something I will argue with everyone about. I think it is equally as important as my osteopathy degree, if not, I don't want to say more so, but when you study literature, you're studying humanity. You're studying our thoughts, our feelings, our ideas, what matters to people and what's mattered to people throughout time. And for me, having that as the foundation of my education, then followed by my osteopathy degree, has really helped me, I think, have a good theoretical basis as well as almost an applied. So I jokingly think of my English degree as like the theory of people, and my osteopathy degree as like applied
I
people in
love
a way.
that. Yeah.
Yeah, I recommend it.
I think like knowledge is never a waste of time because it's always applicable to something like you say. And the fact that you've blended it, you're never going to waste that skill or those talents or whatever you've learned in that first degree. And I like the idea that, obviously there's going to be science behind osteopathy, but also intuitive understanding. And maybe that, like you say, it all blends together quite nicely. And then you've written a book. So it's obviously, worked well. Carry on.
Yeah, no, the book has kind of been, as you say, like the culmination of these two loves of mine, this love of literature and stories and people, and this love of science. So in Help I'm Hypermobile, one thing I decided to keep in, which is the title of the book, these little epigraphs from some literary texts, and I've been very careful in my selection of them, but they all have a special meaning to me, and I think it's an interesting book. But going back to kind of my career, I came to London. I never wanted to go into healthcare at all. If you had told me like 10 years ago I'd be in healthcare, I would have laughed at you and said you were ridiculous. Because what I went through with my mom made me just not want to work in healthcare settings, really. But I ended up here partly because I had wrist pain. I fractured my wrist when I was 10 or so, and I had chronic pain, and I ended up having some treatment. And the type of treatment I had done was called active release techniques, which is a type of manual therapy. So, for those who don't know, manual therapy means treatment with hands. There are many different types of manual therapy that can be done and different ways of doing them. And for me, active release techniques, they call themselves the gold standard in soft tissue care. And although when I first saw that, I was like, oh, they're full of themselves. That's ridiculous. Looking at kind of how they approach things, the scientific basis behind it, and most importantly, how people are certified, because you have to do exams every single year to maintain your certification. And the anatomy is done to a high level, and people do fail them, which I really respect the course for doing, actually. Coming across that type of manual therapy and having an improvement in my wrist pain made me say, hey, like this is a field I've kind of criticized. I'd seen physios in my teens. I'd had different types of manual therapy done by different types of, healthcare professionals. It hadn't helped. When I experienced something that made a difference, I was like, wow, this is really, really interesting. And I thought, I'm a very skeptical person. So I was like, maybe this isn't, maybe this is just a placebo effect, or I'm imagining things. But over time, being able to actually resolve, or the word cure is a very weighted word, so I don't like to use that because it's not the case for most people. Most injuries we see in people with hEDS or HSD are these hypermobility related conditions. But getting to a place where some of my symptoms could be brought down to like a very low level and managed very successfully has really, really helped me. And it gave me this hope. And I said, hey, if we can improve this, and this isn't, I'm not having to wear a brace to sleep every night, which I wore from age 11 to kind of 21, a rigid metal brace to sleep, which again, I should have been referred to someone, but I never was. But if this type of treatment, can help me improve my symptoms, it helped my wrist. Can it help my neck? Can it help my shoulders? What else can I do? I then started, did my osteopathy degree. I was very lucky in that I was able to work with some relatively high profile professional athletes. So I was exposed to this world of what happens if we have kind of an unlimited budget. What can we achieve when we have all these different resources at our disposal? So I worked with athletes initially, but then I kept being referred the more difficult cases over time. And there was this point, I remember on Instagram, I changed my profile to say I work with complex, chronic, and treatment resistant cases. Little did I know that the majority of those were going to be hypermobile. At that point, I was realizing that I too was hypermobile. And then one day I just said I specialize in working with hypermobile patients. And my career's just gone since then, basically.
Yeah, yeah. I mean, it's so interesting, isn't it? Because you kind of like attract what you know, don't you? What you're talking about and what I hear so much, but I hear it, and listen, it's my personal life, it's my kids, it's me, it's my family. I know that we have hypermobility running very, very strongly throughout our whole genes. I had used to go to physios all the time, lots of different back injuries, pain, hip problems, lower back issues. And the only time I have had any relief is when I went to see an osteopath for the very first time. And my brother as well had suffered with chronic back pain. And he then went to an osteopath. And ever since then, the pain is never chronic. And if it comes back, we go to the osteopath, we have a bit of a reset. And I just feel it so intuitively in my body. Like I can feel when, and it's always stress related. It's always when I know that I'm holding a lot or my nervous system has been dysregulated. You know, when I was writing my book, I would have my osteopath in the diary every 4 weeks as preventative. You know, with my kids, my daughter, she was doing her GCSEs. She was getting neck pain, arm pain, shoulder pain, took her straight to an osteopath. Interestingly, my youngest daughter, she's the athlete of the family. She plays a lot of netball, like non-stop netball, running, football, everything. She's also got ADHD. That's how she discharges her energy. She's also, as young as she can articulate herself, has talked about painful legs, restless legs, sore legs. You know, I've had magnesium sprays, hot baths, massage, everything that I can think of. You know, I've taken her to osteopaths and she calls it her growing pains, but I know it's not her growing pains. And I know this is a story that so many people hear. Tell me a little bit, you know, if people are listening to this for the first time and they're relating to all of this, what is the difference between osteopathic treatment and going to a physio?
So within these different musculoskeletal kind of disciplines, if we think of it like that, or professions, there are different certifications or different treatment protocols that these professionals can be certified in. I'm very much of the view where I think that there's good musculoskeletal healthcare providers have more in common than more that differentiates them. So if I had an injury, the top 3 people I'd wanna see, there's an osteopath in Berlin that I would try and seek out. There's a, physiotherapist in the Netherlands and a chiropractor in California, just to show you kind of like there are excellent professionals certainly in every profession. But to answer your question, in terms of the differences, I think that osteopathy has a very holistic foundation. So there's this idea where you have to look at the person as a whole. You know, it's kind of an example of that, just an aside. When a patient comes in to see me, there are 2 questions I always ask at the start of the new patient appointment. I ask them first, if I was a fairy godmother within reason, what would you like to leave here with from today's appointment, to kind of make that immediate goal to make sure I deliver on what they're looking for help with. But the second question I ask is today a good day, a medium day, or a bad day? And if you were to assess me during an appointment and say, what's really like osteopathic about this healthcare provider, you know, taking into account that kind of person's mood or energy, or just a greater emphasis on that. I think a lot of people would say that's more like a osteopathy trait. And again, I don't want to say like there are physiotherapists who are not doing that. There absolutely are healthcare providers in every musculoskeletal profession who will work in a more holistic way. I just think osteopathy perhaps emphasizes that a bit more. I'll say the one thing that's a bit tricky with osteopathy as a profession is there is a huge variation in healthcare providers. So I work in a very what you would call structural or mechanical way. I am not a craniosacral osteopath. There are things in my profession where other people do things where I don't understand them. I wouldn't feel comfortable with the trying to justify them from a scientific perspective necessarily. So you get a whole breadth of healthcare providers. But in conclusion, like I'm so happy to hear that osteopathy has worked brilliantly for you as like a overall profession. But I would tell people just find that excellent person and that excellent professional, whether it's an osteopath, a physiotherapist,
Mhm.
or even a chiropractor. And I will say, just to be clear, in case people are listening, I do not adjust my patients. I don't click joints. I know that that's, you know, people think that's synonymous with chiropractic, but there are chiropractors who also don't do chiropractic adjustments.
Okay. And
So the
is there,
field is small.
yeah, no, but it's interesting, isn't it? Because I've gone to a couple of different osteopaths and they have been quite different in their techniques. And I mean, what I've always liked about it is that they do ask those questions straight away. It's like, what's your stress load? Tell me a little bit about, you know, hormones, or tell me a little bit about, like you say, sleep and all of that. Where when I've been to a physio, and I really don't want to knock physios, it's been, what have you done? What's the injury? And I'm like, well, I haven't really done anything, you know, like I can't really think, you know, maybe because what's happened is when I've thrown my back out, It's been bending over to the dishwasher. It's been the dog like pulled me a little bit. And I know it's the incremental pressure, the stress load over the past 6 weeks, or maybe the lack of sleep, or maybe there's just been something hormonally not quite right. And again, because I've been going through perimenopause, my fluctuations of hormones, I also know now how intrinsically linked it is to ADHD. And so now I understand ADHD adds to the bucket of stress, the tension, the internal noise, the constant catastrophization of whatever's going on in my brain. My nervous system is holding it. And the way I see it is my nervous system kind of like snaps and my body responds to that. And the discharge of energy that I get with an osteopath. So one osteopath that I've worked with, she does that sort of the rocking and goes through the thing. And even that in itself, I'm like, oh, I can feel there's something like coming out of my body. Would you say that's quite a neurodivergent trait to kind of almost feel that coming out of your body?
Yeah, I would say talking about the technique you're mentioning, so I think you're describing a harmonics technique or an oscillatory technique where people just kind of very gently will rock joints or move joints in kind of a rhythmic way. That doesn't make up the majority of my work, although I will use that with patients where it's appropriate. But in terms of that type of rhythmic movement being either like soothing or symptom improving, shall we say, I think that makes a lot of sense. And it's certainly consistent with my experience, even in terms of exercise. So Professor Keith Barr, he's an expert in connective tissue, not in the hypermobility space, although I really think he should start to do research in this field. But he splits exercise in one lecture I've listened to by him. He kind of divides it into rhythmic movements. So swimming is a rhythmic movement, rowing is a rhythmic movement, dancing even has a rhythm, right? It's one movement flows into the next versus more isolated movements. And I can't remember the term he uses, but non-rhythmic, let's just say. As someone who I am not currently diagnosed with ADHD, but when you're present online, people absolutely start to make some observations for sure. But as someone who certainly potentially needs to go get an ADHD assessment one day, absolutely, I can say that I find rhythmic movement soothing. And whether it's someone else doing it to me in a harmonics technique, or whether it's me incorporating it into exercise, and it makes up the foundation of my approach to exercise for myself, it's something which my nervous system needs. So I
Mm.
totally get what you're saying there.
Yeah. So, I mean, you mentioned connective tissue, and we know that this is all highly connected with the hypermobility spectrum disorder, would you call it, or difference? I don't know what's the
So I have a box. So my book, like your book, which is brilliant, by the way. My book has all these little boxes because I've tried to make it very ADHD friendly because we know the correlation is huge between hypermobility and ADHD. But I have a box, a little text pop out box, or whatever you call it in my book, where we talk about disorder, syndrome, condition, and disease because these terms are all used interchangeably, and it's so confusing for people who need to speak or write or talk about these terms. So in terms of hypermobility spectrum disorder, firstly, it's typically plural. So they say hypermobility spectrum disorders, which is confusing, but some research papers, they'll put it as singular as well sometimes. So there's a little, if you see it written different ways, that's not my fault. That's just how it's currently being written.
yeah.
But it is described as a disorder right now. When it comes to hypermobile Ehlers-Danlos syndrome, again, that's described as a syndrome. In terms of different meanings, syndrome tends to be something where we can see what's happening in the person. We see this pattern. In terms of a syndrome, we see this kind of pattern of symptoms, but we sometimes, when we use the word syndrome, we don't know the exact cause. So, irritable bowel syndrome, we know that there are these symptoms that are presenting in someone, but we don't know the exact cause. Now, the annoying thing is that this is not a hard and fast rule, but in a general sense, when you see syndrome, you can kind of think of that. Disorder is hard because it has a lot of negative weight attached to it, and I, as someone whose first study and first love, I wanted to be an English professor. I love my literature studies, so I care a lot about the words that we use and how we communicate. But disorder just sounds, it has more of a negative connotation. And it has also a like a negative mental health, I think, attachment as well. I prefer the term condition. I think that condition right now, it's kind of value neutral. And it's what I use sometimes when talking about these issues in a broader sense. But from a technical terminology perspective, yes, it is hypermobility spectrum disorder or hypermobile Ehlers-Danlos syndrome
Yeah.
or other conditions because they do exist, the hypermobile ones.
Yeah, I mean that's the thing. First of all, I totally agree with you. I feel like condition feels like it's something that can be improved, that can be lived with, whereas disorder, just you just feel like there's no kind of like coming out of this now. And I know from your work that you help people live well alongside this, with the awareness, with the understanding, um, understanding triggers. And I would love to talk a little bit about this as well. I guess you've got people from all walks of life coming into your clinic, and I know that you are a clinician at first. You see people a few times a week, which is the most important thing. We've got the research. We desperately need more research, but we need people on the ground, seeing the people, hearing the stories, and helping people connect the dots. I mean, are people coming in to you with any understanding of what's going on, and you're then having to say, have you heard of this? Do you understand the correlation with neurodivergence? Have you had an assessment, for any of this? And what kind of reaction are you getting from people when you're having to explain this all to them?
Yeah, I see different types of patients. So I'm seeing more and more patients who are absolutely just they've done a ton of research and they're coming in. And what frustrates me sometimes is when these are incredibly well informed patients who've been told by other healthcare professionals that they're not well informed, but they actually are. So these are people who are saying, "Hey, I have these symptoms from my research. They seem like they might be consistent with this hypermobility related condition, but I'm being told like I don't know what's going on. What do you think?" And I have to tell that patient like, "Hey, you've done a great job of this research. Like I'm so impressed by what you've done with no support, and I'm so proud of you for doing this. This matches up with what you're saying. This I'm not sure about, but let's get an opinion from this other medical specialist." So those are the patients like I feel really frustrated for them because they're putting in the legwork. And these are people often who have fatigue issues and health issues, and they're spending that time and energy doing this and then hitting walls. So those patients, when I see them, I try to make sure they know that they've done a brilliant job, and I try to give them that energy to keep going, in ways that positively impact their health and are clinically indicated. I do see patients where all of this is new to them, or they've had inklings, as you said, like where they know that something's not right. They know that something's been going on. There's a sense of unease. And I see patients where I'm that first person, certainly, to kind of connect the dots and explain things. I try very much. I think there's a tendency sometimes online to attribute everything to hypermobility or, everything. It comes back to that. And although many, many things do, it's not everything as well. And as a clinician who cares about keeping patients safe, I'm very cautious because sometimes people do have, heaven forbid, cancer or something else, which is not hypermobility related. And I have to make sure that I'm keeping my patients safe and looking out for that. So I try to not fall into the trap of like, it's all hypermobility, but of course, a lot of it is. But seeing those patients where we talk about kind of the intersection of different conditions or what's co-occurring and what we know from research right now, or what we don't know from research yet, but what there's a good physiological basis for and what is currently being researched. Seeing that type of validation like just light up in their face and seeing them just sometimes happy tears or whatever, like it's the reason why I love my work so much is getting to really make a difference in these people's lives because they're all my patients. Maybe I'm biased. I think they're the best in the world. Maybe I'm just lucky or whatever. But these are incredible people I have the privilege to get to work with. And it's just a great privilege to get to help them in this way.
Yeah, I mean, I think that validation that you're giving them when they're coming in, because ultimately we've had to be our own advocates. And what I'd love to ask you is, maybe if someone is listening to this now and they're really just kind of like, oh, yes, I actually have had that chronic pain, that neck pain, that back pain, shoulder pain. Maybe it's not been to such a heightened degree that they've really suffered, but it's there. They take maybe daily paracetamol. Maybe they have had to go to a physio a few times. Maybe they've had a few injuries, every time they do sport or they do a certain challenge, but they just kind of bypass it because very often we're just taught that pain is normal and just crack on, especially as women. Can you give us a little bit of if you've had this, and this, maybe it's start having a look into whether it's EDS or hEDS or hypermobility, so people can do that research for themselves, they can feel more empowered?
In terms of lists of things, I think that firstly, we need to think of what is zero pain. So if you had asked me when I was 21 if I had chronic pain, if there was like a survey, I would have ticked no. Or if I had any, if I experienced pain that was affecting my life, I would have ticked no. Bear in mind, I was having headaches that had me in bed for days at a time. My neck was in agony. I would struggle to stand for long periods of time and so on, right? And at that point, I'd had multiple fractures, multiple surgeries. Like there's a lot in my health history where I wouldn't have even have acknowledged it. And I think as much as that can be a mental state that's associated with some neurodivergent conditions or ways, just trying to kind of filter or focus on what you can or ignore the rest or give it that attention or not give it that attention. I think it's also just a coping mechanism for dealing with the trauma of having a connective tissue condition as well. So I don't want to dismiss people's understanding of themselves or say, "Oh, well, if you think this isn't you, then like you're wrong. It's you." No, you know yourself. This is ultimately a conversation and discussion and thought process you need to have with yourself and your healthcare providers. But in hindsight, I just wish I could scream at myself that what I was going through was not normal. In terms of things that would make me, if I had a child, if we're using the example of a young person, kind of flag that and be like, like maybe we should, talk to a medical doctor, a healthcare provider of some kind. In children where we're seeing firstly growing pains. Growing pains, they do not exist. If there was a systematic review, I'll send the link for you to put in the podcast. They are nonsense. There is no clear medical consensus on what growing pains are. If I ever have the time or energy to do a informative campaign on the subject, I will, because that is the first negation and the first instance of what's dismissal for someone's pain and someone's lived experience. So that young child, whether it's me or one of your children or someone else listening to this, when they're told, "Oh, that's you're too sensitive. It's not pain. Stop being so dramatic," which is kind of what I was told. You learn very quickly and from a very early age. We're talking often age 3, maybe 10, maybe a bit older or younger, but childhood, your brain is developing and you're taught ignore what you're feeling in your body. You're wrong and your feelings don't matter from a very early age. So that is terrifying and serious. Um, so in terms of growing pain, anytime there's a young child where pain is affecting their sleep, that for me is a flag where I want them to speak with their medical doctor, healthcare providers, someone who's so appropriately qualified to help
Mhm.
them with this. When we see children with gastrointestinal issues that are unexplained, again, diagnoses of IBS are handed out like candy.
Yeah.
It's meant to be a diagnosis of exclusion. I don't know about anyone else listening to this. I had no testing done. I had nothing.
No, neither did I.
Yeah, they were just like, "You have IBS." And something which I have talked about before, but which I will mention here, it's a health podcast, so I assume it's fine. When we see children with episodes of constipation that are longer than a few days, red
Mm.
flag. I went 3 weeks without a bowel movement. I was, like, 14 and talking to my friend being like, "Hey, like, have you ever gone this long?" 'Cause I was 14 growing up in London, Ontario in Canada, and I didn't know what was normal or not. And I had no idea that 3 weeks is when things get really serious. Like, I should have been potentially going to the hospital. I should have had a referral at the very least to a gastroenterologist after that. Nothing happened, of course, but anytime I see episodes of this is gastric dysmotility. So, constipation would be that gut moving too slowly or not at all in sometimes, which can happen and which is an incredibly serious issue. There's also, of course, gastric dysmotility the other way, where it moves too fast. And there are people who will have both, which is really confusing. I had a patient yesterday, and she was telling me how her medical doctors dismissed her because they're like, "Well, you have both, so it's okay. You're not one or the other." And it's like, no, these people that have, I call it never normal. So they're either end of the stool chart, they're never in the middle. These people need gastroenterology investigations and assistance and support.
Can I ask about that? Because
Yeah.
it's interesting. Again, one of my kids has this, and she also has quite serious sort of like hormonal, whatever you want to call it, heavy periods. It's been muted about endometriosis because endometriosis, the similar symptoms as well. Does this overlap? Do you see an overlap of this type of kind of presentation of definitely within women and girls with the
Yeah.
hormonal issues?
It's not just me. So in terms of the research, this is one of the things there is excellent research on. A very big systematic review came out in autumn of this year. My brain is not working today for recalling research, but I'll send it to you. It'll be in the show notes. But the correlation is very, very high for conditions like endometriosis. I believe polycystic ovarian syndrome as well. Dysmenorrhea, so just period pain without a known cause, is incredibly high. So we have good evidence now that there is a clear correlation between these kind of gynecological or period related health issues and Ehlers-Danlos syndrome and hypermobility spectrum disorder. So in terms of young people, with a uterus and periods who are having these issues, yes, they should be acknowledged. Again, I was someone who had undiagnosed PCOS. It's a whole story. I'll say it real quick. I went to my doctor with the medical diagnostic criteria. I just started my osteopathy studies. I was learning how
Mhm.
healthcare worked. And I said, hi, these are the criteria. I have these. Therefore, I have this condition. I have PCOS. And I was told, no, you can't have it because you're too skinny. And I said, but weight does not appear on the diagnostic criteria. And then the GP, this happened to be in the NHS, but she was just like, no, you can't have it. And I said, but I have it. So we just ended up in an impasse. I left the office and tried to find ways to manage it myself, which luckily I've been able to manage and self-improve to a large extent. But the dismissal of period-related issues is a massive problem, and it does probably disproportionately affect people with hEDS and HSD based on current research on co-occurring conditions.
Yeah, I mean, and thank you for that, because that again is validating. Can I ask, you talked about headaches. Again, are we seeing a higher proportion of migraines, jaw pain, headaches in this? And can osteopathy help with that? Is it sort of like a release that you're able to do to help reduce the migraines?
Yeah, so when it comes to headaches, firstly, safety is paramount. There's something that healthcare providers of all kinds, whether physios, osteopaths, or otherwise, need to be trained in screening, because there can be headaches that are very clinically concerning. So if it's a particularly new headache, if it has certain types of visual changes or a specific intensity, we want those investigated. And I say that, I always ask patients, have you spoken with your medical doctor? And sometimes they're like, yes, but like they told me it was anxiety or whatever. But I have to ask that just to try and make sure that this is being managed in a safe way. But in terms of headaches, in your question, there are different types. So there are some headaches, there are true migraines, which are more of a centrally mediated neurological phenomenon. So I compare it to almost like the Northern Lights. The brain just gets weird, and these people will get sometimes aura or different sensations or symptoms there, right? Or sensitivity to light as well. And that is centrally mediated. In terms of success with treating migraines from a manual therapy perspective, I I haven't seen a lot of good evidence from a research perspective or anecdotally in terms of being able to improve those in a direct way, as in like we treat this and this helps, if that makes sense. Maybe as that person's health improves as a whole, maybe those symptoms can reduce, but they're very much a centrally mediated kind of brain northern lights almost situation. In terms of other types of headaches, though, so what I had, and which I still get a few times a year, but very rarely, I would diagnose them. And again, I went to my doctor. Was I diagnosed with anything? No. So this is just my self diagnosis in my view.
Mhm.
I believe that I have cervicogenic headaches with migrainous characteristics and some involvement of my trigeminal nerve. So whether you call it a neuralgia or an irritation, I
Mhm.
would get intense pain at the back of my eye, like it was being strangled, intense pain in my teeth, which was terrifying because I've had jaw surgery and a bone infection 5 years after the jaw surgery. So every time I would have the headache, I would be so anxious that I was having a recurrence of what I believe was probably a chronic osteomyelitis. Again, that was not diagnosed. I went to the hospital, was told I was a drug seeker, and it's a long story on how I didn't die from that, to be honest. But, anyways, every time I had a headache, I would go buy a thermometer because I was so anxious I had a bone infection, which is not normal, to be clear. So with that type of headache, to use myself as an example, the thing that made me believe it was treatable was the fact that I would have neck pain as a prodrome. So I always ask my patients, what happens before you get a headache? And even though I will see these patients, and it is horrific, these headaches are the thing I'm most scared of having to deal with again in a significant way, personally for me in terms of symptoms. But I will ask these patients, do any symptoms consistently kind of occur before these headaches, or do you know it's going to happen? Can you feel it coming on? The ones who I believe have true migraines, they say no, it's just kind of random. It'll just happen pretty quick, and there's no neck pain associated with it. The patients who have what I believe are the cervicogenic headaches with migrainous characteristics, these patients will say, yes, I have a sense of dread. I know it's coming. I can feel it going up my neck. It makes me sick. As someone who's had that, the lead into the headache is almost worse because you're on horrible roller coaster ride. And if you don't have ways to manage it, you can't get off it. And you know the full symptom picture that's coming and that's waiting for you. So with those type of headaches, patients are obviously suffering, but I get really happy because it means that there's something potentially that we can do. In terms of treatment, I think we need to think about how more often how peripheral nerves are as much connective tissue as they are nerves. So the sciatic nerve, if you removed it from a body at the gluteal region, so the buttocks, if we take it out and put it on a tray to look at it, it's something like 80% connective tissue. It's over 70 certainly. And that's because the sciatic nerve and all peripheral nerves to an extent have connective tissue within and around them. So they have the epineurium, the endoneurium, and the perineurium. So think of it like the almost the cable, you know, if we have a little like charging cord, it's like the wrapping around that cord, if that makes sense, as well as also within it, though, interestingly. And when it comes to treating these headaches, what I often look at in patients, I'll just mention these structures in case they help someone out there dealing with this. I look at the dorsal scapular nerve and the spinal accessory nerve. So these are two nerves that go from the neck between the mid back and the shoulder blades, or kind of upper back area. And looking at those nerves and how they're being irritated, and sometimes finding ways to treat those structures, whether through, in my case, the active release techniques that I do, or prescribing exercises to build that mid back strength and develop that scapular control. That is something which I can say anecdotally, and I don't have studies, but I can say it's one of the most common presentations I treat at clinic. And although it is certainly multifactorial, there can be hormonal contributions, there can be nutritional contributions as well. So people might, if they have ADHD, be forgetting to eat, for example, and you get in a caloric deficit, and that can be a trigger. But finding ways to deal with these headaches is like one of my, I don't know. I'm a generalist. I deal with all types of injuries, but headaches and neck pain are probably something I certainly specialize in.
Yeah, no, I'm asking this because again, what I'm hearing is that there's just not enough understanding of this neurodivergent crossover of if someone's presenting with, say, gut problems, migraines, neck issues, and that clinician understanding, go, oh, let's ask some more questions. Like, I wonder what else is going on for them, and making that connection.
Well, and I think it's also gatekeeping, which is a huge issue. So I'm in a very privileged position where I've gotten to study. You know, I did a 4-year degree on the musculoskeletal system, basically. So in terms of dealing with these headaches, although I had treatment done by other musculoskeletal healthcare professionals, manual therapy at the time, and so on, a lot of what I was doing was self-treatment interventions, as I call it, or you can call it self-massage, but there are things you can do that aren't really even technically massage. One of the single biggest, I think, obstructions to patients making progress with these really chronic and complex issues is that in patients who are hypermobile, and again, we can't use it synonymously with neurodivergence, but as you've said, there's such a huge correlation, you know, patients who are hypermobile and neurodivergent. These are people where they have a high injury rate because of the hypermobility. The connective tissue is more delicate, it's more vulnerable to re-injury or symptom aggravation. So we have a high re-injury rate. Patients can only see me so often. I'm very, very booked, and it's also, you know, there's a cost and time and travel associated with it potentially, right? So when I'm seeing these patients, I know the re-injury rate is high. I need to find ways. If I find a way to successfully help improve their symptoms in the treatment room, my first thought is, what can I do to help these patients be able to mimic whatever I've done here at home? What can I teach this person? Because then when they go home and they have that symptom occur, that horrible feeling of dread of that headache starts with that neck pain, they have something they can do, whether it's exercise, whether it's self-massage, whether it's another type of an intervention of some kind. They have something which the patient and I have agreed on, which they're going to try. They're going to come back and tell me, Alex, that was brilliant, or Alex, that didn't help at all. And that gives me information to then help formulate more specific interventions for them to do and to develop a very much, it has to always be individualized, unfortunately, because every person is slightly different. Some
Mm,
patients find cold caps helpful. If you put a cold cap on me when I have one of these headaches, I will not have a positive
yeah,
reaction,
yeah,
put it
yeah,
that
yeah.
way.
No, I
But
wouldn't either.
some patients love them. I will never understand it. But anyways, basically, having this real passion for developing self-treatment strategies, because I like to have successful outcomes with patients, to be entirely honest, both for myself as a professional and my view of myself, but also to help my patients and help them feel better, of course. it is the most important part of what I do. And going back to what you said at the start about these patients who do this research, my patients are my most valuable asset in terms of actually helping improve their symptoms. If my patients were not as motivated and hardworking and curious as they are and willing to learn, I could not achieve the clinical outcomes I do. So working with that and working as a team, that is the single most important thing.
Yeah. I mean, I love the idea of self-treatment because, like you say, a headache comes and we can't be like, oh, we'll see you in 2 weeks. We need to have that autonomy and that sovereignty to feel like, yeah, I can deal with this. Like I have tools in my back pockets. Why I wrote my book, there were so many things in there. I was like, right, I want these people to be able to know they don't need to see a coach, they don't need to see a psychiatrist. They can empower themselves, teach other people, and have that toolkit. And I guess, is that what you've written your book for as well? I want to hear a little bit about like self-treatments that you've put in the book, because this is going to help so many people, because not everyone has accessibility to private,
Yeah.
treatments.
No, I wrote the book because when my symptoms were at their worst, I had no money. I was a student. I couldn't afford anything. Like, so it's the book I wish I had had. I'm very
Hmm.
much like a high-low person, if that makes sense. You know, with fashion, when people mix like a really high-end brand with
Yeah.
something that's a bit lower end, we need
Yes.
high-low healthcare because there are
Yeah, I
some
love that.
things. Yeah, and there are some health issues where I will tell patients, "You need this test. Like, this is really important. This has to be done correctly. Like, please." I'll tell patients, "Don't see me." I'm like, "I can't see you. I don't wanna see you again until this is done," because that's how important it is to their health, right? So that's, like, kind of the high end. But there are so many things that can be done from a cost-effective perspective. Although, of course, it is important to see healthcare providers, and I believe very strongly, in patient safety, and there is certainly a role that's played there. The reality is that there are people out there manage with symptoms that they can have positive effects on in the here and now, and that they need to get going with. And people forget that a diagnosis is a privilege as well. So that's why I called the book Help, I'm Hypermobile. I didn't say Help, I have hypermobile Ehlers-Danlos syndrome, because I didn't get my diagnosis for years because I just couldn't have afforded it and I couldn't have accessed it. And a lot of my patients, they almost commit the crime of looking too well. Which again, these are people, in terms of healthcare professionals, I see a lot of people who are co-diagnosed with hEDS or HSD and ADHD, and these will be people who are in very accomplished roles sometimes, and people are suffering. I'll hear about the details of their day-to-day life and what they're struggling with, but they hold everything together just well enough to be competent, not even competent, to be exceptional at their work. But behind the scenes, these people are really having a hard time. So, Help, I'm Hypermobile, your how-to guide for HEDS, HSD, and life in a hypermobile body. It's truly the book I wish I had had. I believe very strongly in the democratization of healthcare. So for me, as much as I'm happy to see patients in a clinical setting, I wanted to, like you, try and help the people who couldn't see me, help the little 21-year-old me who needed that help and who couldn't have afforded my appointment rate, but who could afford maybe I don't know, 12 pound, 16 pound, whatever the price will be. They could afford that book. So that's why I wrote it. In terms of the structure, we talk about physiology and anatomy, but I try to make it in a fun and interesting way because I hate when things are boring, because this stuff isn't boring. It's like thrilling, in my opinion, at least. So looking at the science and making it, focusing on what's useful. I think as a healthcare provider, when I go to conferences, I care about research that is presented with a focus on what's called clinical utility. So, how can it help me help patients? With the book, I want to focus on subject matter that helps patients help themselves, and that's not just superfluous, kind of useless stuff. So, there's really been very much a laser focus on that. I want to prepare people as well for talking with healthcare providers. So it's a book which I've kind of written to help equip people for these discussions that they might need to have. And it's a book which answers all the questions people have. The second part of the book is an FAQ of just the questions that I've been asked repeatedly over the years. And for me, it's been great to get to really give an informed, research, evidence-based answer to, all these different questions that crop up again and again and again. Because I don't know about you, but it's like I'm being asked the same questions I was asked 4 years ago, and it's no fault of the people who are asking me these questions. It's just that there's still not enough awareness that these questions are not answered in the public mind.
Yeah, I mean, it sounds like such a valuable book. And I know, your podcast as well is fantastic at addressing all of this. I think we need to get out of these sort of 1 minute, TikTok videos and Instagram reels where yes, they can be very helpful, but there's no nuance. We can't expand on this, and it can't be, but yes, so there's this, but that, and you need to check this. Like you say, these conversations are very, very important, because thankfully we've got this awareness now, but now we need to get, dive deeper. 10 years ago, a book on hypermobility would have been very, very niche, and you would have only been able to find it in like a health food shop or something like that. But now it's coming to the mainstream. And I do feel like there's a change in the tide of like people wanting to feel empowered with their healthcare. Maybe it sadly has been because they have been let down by mainstream medicine. There's just not been enough knowledge, there's not been enough awareness. We talk about medical gaslighting, and I don't ever want to throw doctors under the bus, ever, because I know that many, many doctors, most doctors are doing a fantastic job with the resources and the training and the time that they've got. But the time is now where we have to start listening to people and putting these new reframes into place of understanding people through different lenses. And the fact that you're talking about hypermobility and giving this accessibility of allowing people to have this, this self-treatment, this understanding of themselves. I'm very excited to read it, and I will be, using it for myself, but also for my kids as well, because I see how it shows up. And I have this tendency to want to fix and treat my whole family, and they often don't want that. And I just hope that as they get a bit older, they find a way to help themselves. So this book will definitely be out. But I'm going to let you go. We're going to put a lot of the links that you've mentioned in the show notes. And if people want to contact you, we'll make sure that we've got your website, book links, podcast. We're going to put it all in the show notes. And then if anybody lives in London and they want to make an appointment with you, what kind of wait time are you on?
It depends. Right now, I think we're looking at like 2 months, 6 weeks at least. It depends on when people are able to be seen as well. My schedule will open up a bit more when the book is out. I do offer online appointments. I've seen patients from almost every country you can imagine at this point, which has been one of the coolest things about my career. So certainly online, in person. I do workshops as well occasionally, which are brilliant. And yeah, people are always welcome to reach out, message me. I do genuinely try to reply. And the best part of my work has been getting to connect with people and with other professionals in this space like you. It's truly the most, I guess, rewarding part. Thank you for having me on today. And thank you for your shared passion for something which connects us, which is certainly hypermobility and ADHD.
Yeah, absolutely. Well, thank you so, so much. Really appreciate you being here, and wishing you lots of luck with the book.
Thank you.
Thank you for being here and listening to today's episode. I just want to remind you that if you are looking for more support on your ADHD journey, there are so many resources waiting for you over at ADHDwomenswellbeing.co.uk. So inside the ADHD Women's Wellbeing Workshop Library, you'll find practical and compassionate guidance on topics such as nervous system regulation, rejection sensitive dysphoria, perfectionism, emotional regulation, hormones, parenting, and so much more, all designed specifically for late diagnosed neurodivergent women. You can also explore my new book, the ADHD Women's Wellbeing Toolkit, which was published by DK, which is also available in ebook and audiobook, which is packed full of tools to help you feel calmer, more regulated, and more like yourself. And if you do crave a bit more deeper connection and ongoing support, come and join us inside the More Yourself community. It's a gentle space for learning, reflection, and connection with other neurodivergent women. And you'll also find the recordings from our first ever ADHD Women's Wellbeing live event, which brought together incredible speakers and a room full of inspiring women for a truly special day. We have recorded it all for you, and it's there to buy. So whether you're just starting your journey or looking to go deeper, there's something there for every stage. Just head to ADHDwomenswellbeing.co.uk to explore everything. And as always, thank you so much for being here and for being part of this community.